Dear friends, welcome all to this webinar from the ERN GUARD-Heart, organized by the thematic area electrical diseases. We will discuss two cases, and the first one will be presented by Irina Rudaka from Riga. She agreed to present a case that was discussed through email in an earlier part of this year, and then I will comment on it later, and then I will present the second case myself. I hope this can be interactive. If there is any comment or remark that you want to make, please use the chat and we will pay interest to that. So Irina, can you take the screen?
Yes, thank you very much. So hello, everybody. My name is Irina Rudaka. I'm a cardiologist working in Riga, Latvia. So today I would like to present a clinical case about an investigation of a sudden cardiac death cause. Following slide, please. So this story started in February 2021 when a young man, he was 31 years old, experienced a cardiac arrest during sleep. Fortunately, his wife was well educated and she started CPR because he was not breathing normally and was unresponsive. Could you please, yes, so when medics arrived, they recorded an ECG, and the first treatment recorded was VF, ventricular fibrillation. They performed defibrillation and successfully restored spontaneous circulation. Luckily, CPR was performed at a high quality and patient did not experience any hypoxic damage of the brain. Following slide, please. So what do we know about him? Before this episode, he was working in the IT field. He says that previously he was completely healthy. He does not take any medications on a daily basis. He is non-smoker. And his family history is unremarkable. He is the only child in his family. Both of his parents are still alive. His mother experienced myocardial infarction, but there was no cases of sudden death, even syncopes or premature deaths, any cases of ICD or pacemaker implantation in the family. Following slide, please. So when patient arrived at the hospital, an ECG was recorded. Could you please proceed? Yes, so and on this ECG, there was a sinus rhythm, but two abnormalities were marked. So there was prolongation of PR interval and also markedly prolonged QT interval. Following slide, please. This is actually not the ECG on the following day, but rather on the day at the discharge. Proceed, please. So on this ECG, actually, we see that now QT and also PR interval are within normal ranges. So prolonged QT interval was recorded only on one ECG. Okay, next slide, please. On laboratory findings, there was elevated liver enzymes, slightly increased C-reactive protein, as well as elevated high-sensitivity troponin and NT-proBNP. So, of course, it can be expected in the patient after CPR. Potassium and also other electrolytes were within normal ranges. So we concluded that no QT interval prolonging factors were identified in this patient. Next slide. We also performed an echocardiography and no anatomical or structural abnormalities of the heart were recorded. So all measurements were within normal ranges. We also performed coronary angiography to exclude any coronary artery disease or, more importantly, any anomalous anatomy of coronary arteries that can result in ventricular fibrillation, but no stenotic lesion or no anatomic variations were observed. Following slide. So we concluded that with high probability, this patient has long QT syndrome, and to treat him, we decided to implant an ICD for secondary cardiac death prevention. And we started the treatment with the beta blockers. Following slide, please. So genetic testing also was performed. We performed a whole exome sequencing and analyzed 349 genes. And the result came back that patient has a likely pathogenic variant in KCNQ1 gene that is expected to result in loss of function of the protein. And KCNQ1 gene is known to be associated with long QT type 1. Following slide. So our question is, does this patient really has long QT syndrome type 1? And does this genotype, genetic finding, actually explains patient phenotype? Thank you.
Thank you, Irina. Is there anyone in the audience who want to comment on this case and particularly answer this question? Is this long QT syndrome type 1? Thomas Robijns asked Irina, was there an exercise test performed?
No, in this patient, exercise test was not performed.
I think that is a relevant remark,
Yeah.
which would also help with this diagnosis. Ashmalin test?
No.
Okay, then let me try to share my screen and I'll give you my considerations. When you disabled, I host disabled participant screen sharing. Irina, there was one more question. Were there previous EKGs available?
No, as I said, a patient said that he was completely healthy, and this was like almost the first visit to hospital or to doctor, so he did not have any previous ECGs.
Thank you. So we had a discussion through email, also with Leah Cotti, and but these are my considerations. First of all, I do believe that this KCNQ1 variant is pathogenic, and the initial EKG would actually be compatible with a long QT syndrome. However, the trigger, you may recall that this patient died during night, is not at all compatible with long QT syndrome type 1. I don't have a backup slide for that, but you all know that long QT syndrome type 1 in particular has events during exercise or faster heart rates, and occasionally that might happen during sleep, but it's not a very common trigger in LQT1. And moreover, the type of variant that is identified, this is a nonsense mutation that is in general relatively benign, and that comes with some backup slides. This is a paper with a registry long QT patients type 1 from Arthur Moss, late Arthur Moss, from Rochester, New York, from Japan, and from our group. And this is with 600 patients with LQT type 1. And the genotype-phenotype relation for these patients is as follows: if there is a mutation in the transmembrane domains, then there is a high likelihood of an event in the first 40 years of life. And note that the majority of patients do get symptomatic by age 20. But if it is in the C-terminus, or in this case, if it is an haploinsufficient variant with 50% reduction in IKS, these are the relatively benign. It's not to say that these patients don't have symptoms, they do have, but in general, it is less significant than the dominant negative variants that are mostly located in the transmembrane region. So this is an repeat of the same graph, just a bit larger. This variant is haploinsufficient, and that is relatively benign for long QT for KCNQ1 variants. So if you bring that together, then I would not immediately accept this variant as being causal. I think it is relevant for the therapy of the proband, because you still would accept it that beta blocker is needed, and you will probably still implant an ICD because the patient was resuscitated. But if you are sure that this patient has LQT1 and was not on treatment and not aware of the disease, you may even consider just starting beta blocker in a resuscitated patient if all the circumstances are typical for that. But it's certainly relevant for counseling, because if you now counsel the family members only on a genetic variant, which what is frequently done with a definite pathogenic variant, then you might send patients home without this particular variant, and these patients might still be at risk for another cause of this cardiac arrest. So in the counseling process of this particular family, I would definitely combine it with clinical tests, not to miss any other disease. And there are descriptions in the literature. I saw Britt Beckman present in this call. She wrote a story many years ago of a family with both long QT syndrome type 1 and CPVT. The counseling was performed on one of the two, and after the counseling, still patients died suddenly because they had a second disease, which was the other one. These two diseases are very difficult to separate, by the way. But you would have been able, if always exercise tests would be formed, and you would not have limited the counseling to only clinical testing. So I think that is the message of this case. I would like to ask the audience if anyone agrees or disagrees. Please raise your voice. If not, then I assume that everybody agrees, but I'm not sure. It's one question.
This was a question?
Yeah. So, Irina, there is another question. Were the parents tested for the variant in the meantime?
Yeah, currently both genetic and also clinical screening in the family is ongoing. So we are now.
So you don't know yet?
I don't know yet. I don't have any information to share with you at this.
And they had a normal EKG?
Well, yes. So far, I did not find any relative with abnormal ECG.
Okay. Okay. So if there are no further questions, we close this case and we move to the second case, which is the following. That is a case that started like this. There was a 13-year-old boy who died suddenly, no previous history. Circumstances of death are not known, and the autopsy showed a slight left ventricular hypertrophy with some mild disarray, some fibrosis in the papillary muscles and in the atrium. But the conclusion of the pathologist was that it was inconclusive for any specific cardiomyopathy. So the question is, what would you do? I think that is an easy one. I think we all agree with that the family members should be investigated. That means here the older brother and the parents, and the investigation should at least have an EKG, an exercise EKG, and an echo. Now, this was actually done in the individual, in the older brother, and also in the parents. But I have here the results of the older brother, normal EKG. He had an event monitor for 21 days. I think that is a little bit too much. We personally stick to a 24-hour or 48-hour Holter monitoring. But in that event monitoring, there was an event which was judged to be a ventricular tachycardia. It was not very fast, but it was a ventricular tachycardia. And I don't have the recording, but I do have the baseline EKG of this young male. And this is what it is. And based on that, the diagnosis long QT was made and a genetic test was ordered. So my first question to the audience is, would you actually have done genetic testing here? Is that a yes or a no? And I would appreciate some answers here. I would have done it in the diseased individual. That is obviously the correct answer. And I will come back to that later. And only in the index, if possible, that is the same answer, and that is correct. But in this case, it was done in this young male. And lo and behold, a variant came back in KCNQ1, a valin at position 133 was replaced by an isoleucine. And the company in the US, this is a case from the US, in the US, the company then puts on your result that this variant is probably deleterious. And the main argument for that is the minimum allele frequency, which is very, very low. 1 in 30,000 individuals, white individuals, actually carry this variant, and that is considered very low, and that is an argument for being pathogenic. So this is referred to as a class 4 variant by the genetic company. Now, we already discussed that investigation of relatives alive, EKG, exercise, EKG, echo, then has to be done. But in this case, the relatives had the investigation and also genetic testing. The next question is, would you actually start a beta blocker or implant an ICD in this? Let's start with the young boy. Only beta blocker, no ICD, just beta blocker. Consider beta blocker, no ICD, beta blocker, but no ICD. So there is consensus in this audience, part of the audience that answered that. Maybe start the beta blocker, but not implant an ICD. Now, this is in the United States, and this case was actually published by Mike Ackerman's group, and funny enough, his son was first author on this paper published in the Mayo Clinic Proceedings in 2016, so it's not that long ago. And it actually shows, and that is the reason I presented here, that how important it is for appropriate phenotyping and how important variant interpretation is, like in the previous case. So what happened was that genetic testing was performed in the parents, and the father appeared to be positive. The father has 20 more family members that also all appear to be positive for this genetic variant. And because the whole case started with a young sudden death, namely the brother of the first patient investigated, the decision was taken to implant an ICD in this young boy. I don't know whether there was also a beta blocker given. The same story for the father and the same story for all these individuals at this side of the family. And then at the point, somebody within that family asked for a second opinion, because the family started to question whether all this was really needed, because no one was symptomatic. And so one asked for a second opinion in the Mayo Clinic, and the Mayo Clinic retrieved the blood spot card of this young boy. There was no autopsy material available from for genetic testing, but the blood spot card was still available. They did genetic testing for the particular variant, and it actually was negative in this young boy. So this boy did not die from long QT syndrome or this variant at all. They did whole exome sequencing subsequently, and they found a Desmond variant that might actually be even compatible with the slight abnormalities at the autopsy. So this sad story, they also did, by the way, the functional analysis of this particular variant. They expressed it in a system, in a cell system, and they found that the variant had very similar characteristics as wild type. So the variant is not even pathogenic either. And I cannot easily go back to the EKG, but if you have watched the EKG carefully, there's no phenotype of long QT whatsoever. So this story, this sad story, ended up in the Wall Street Journal in October 31, 2016, which is Halloween, with the title, the title, Boys' Cardiac Death Led to Misuse of Genetic Testing. And Mike Ackerman extensively commented on this, and just read the last sentence here. The entire clinical evaluation was a train wreck where wrong conclusions led to wrong turns and resulted in wrong therapies. And so once again, I think it should be stressed, and this case is a very good example for that, that phenotyping of this type of patients need to be done in centers of expertise, and variant interpretation needs to be done in multidisciplinary teams. And certainly before you take all these the therapeutic decisions, as in this case, this could have been avoided when both phenotyping had been done accurately enough and variant interpretation had been done accurately enough. So I go on with the guidelines in this type of cases. This is from Heart Rhythm 2021. It is the Asian Pacific Heart Rhythm Society and the Heart Rhythm Society that made up these guidelines. I had the honor to share this on behalf of the Heart Rhythm Society, and it is a consensus statement on investigation of decedents with sudden unexplained death and patients with cardiac arrest and their families. And the first recommendations are that all this should be overseen by a multidisciplinary team, and that both holds for investigation of sudden unexplained death, but also for investigation of sudden cardiac arrest survivors. And a multidisciplinary team should have within their immediate reach, so disciplines represented: pediatric and adult cardiology, pathology, clinical molecular geneticists, genetic counseling, psychology, which is also important. And you should have access, for example, to neurologists or pathologists, etc. It should be coordinated by one of these people here, a cardiac genetic service with a coordinator, and he or she should be in contact with the patient or the next of kin if the patient died. And then in the end, there is a report. After all the information comes in, a report will be generated, and results of family, clinical, and genetic investigations are collated and delivered to the family and the referring clinician. The recommended for counseling is that if you do genetic counseling, you should is strongly recommended, but that should include, of course, all the information you are able to retrieve. But the second one here is the most important one at this point, that it's recommended that genetic testing in families after a sudden unexplained death or resuscitated cardiac arrest, due to inheritable causes suspected, it should be performed only with appropriate genetic counseling. And would that have been done in the second case that I present here, then this whole drama would probably not have happened. So there are two options then: genetic testing when this after sudden death, when the phenotype is known or where the phenotype is unknown, and I briefly touch both of them. This is the flow chart where the phenotype is known, and when it is in green, it means a class 1 recommendation. So this is a sudden cardiac death with an established diagnosis. The decedent is a family member of a known pedigree, then you obviously test for the genetic variant in that particular pedigree. And when the decedent is the proband, as in our case, targeted genetic testing in the proband can be relevant based on the clinical phenotype identified at the autopsy. and that can be broader with selective reporting. That is mostly in the setting of research. Also, that is a class 1. And at the same time, you start evaluating family members with a pedigree, genetic counseling, and clinical evaluation with the modalities that I have mentioned earlier. Now, this can lead to the identification of a variant, and that subsequently lead to cascade screening. It can also lead to a non-pathogenic variant identified, and then over time, ongoing reappraisal of these variants or gene pathogeneity should be performed. And for that, you need that multidisciplinary team. Also, if there is a pathogenic variant, things like reproductive screening, counseling, and management for affected family members becomes pertinent. If the phenotype is unknown, like in our case, then there is a sudden unexplained death. There is no definite diagnosis of phenotype established after extensive family screening. Then with a class 1 recommendation, you can go on with documented, when the documented arrhythmic death is suggestive of arrhythmia syndrome, that's a class 1 recommendation. If there are specific triggers for arrhythmia syndromes, that's also class 1. And our case would fall in this category, young age, under the age of 40, as a class 2A. But you screen, as have also been mentioned by several of the participants, you screen in the index, in the proband, and not in the family member who has no phenotype. In general, we believe at this time, this is only 1 year ago, that hypothesis-free genetic testing is not indicated. You can do it, of course, in a research setting, but in general, you have to be careful for this because there are really a number of variants of unknown significance that you will identify, and that will outperform the number of variants that are pathogenic or likely pathogenic. The chance is much, much higher that you find something which is of unknown significance. So the example of the long QT syndrome, as in both of these cases, there is good reason to do genetic testing in an index case for diagnostic reasons, for prognostic reasons, and for therapeutic reasons. And examples of all these categories is that for diagnostic reasons is that the diagnosis in a family member with normal QTC still requires genotyping to diagnose the patient. Specific variants that relates to prognosis are more malignant than others. That is, an example was given in the first case. Treatment details are different for different subtypes. For example, the age of treatment, which may be different, extent of treatment, additional treatment, ICD or not, etc. Now, molecular screening for long QT syndrome should be offered to all index patients with a high probability diagnosis of long QT. And that is based on these variables. And altogether, all these variables are in the Schwartz score. So if the Schwartz score is over 3.5, then you have a good reason, class 1 recommendation for molecular genetic testing. And the second case that was tested did not have a Schwartz score at all, probably 0.5 because of the sudden death of his brother, but that was all present in that case. So this child should never have been tested for long QT syndrome. Other genes can, of course, be tested if there is specific diagnosis, for example, Jervell-Lange-Nielsen syndrome or Timothy syndrome or Anderson-Tawil syndrome. And these genes can also be tested in a case where the diagnosis is maybe not as high. So this is the flow chart for long QT syndrome. Only test in cases with high probability, and these are the genes to screen for, and these are the genes that you may add to that panel. In Jervell-Lange-Nielsen syndrome and the other specific syndromes, you can screen one of these specific genes. And then the last two recommendations here for long QT syndrome is that variant-specific testing is recommended for family members and appropriate relatives following the identification of a disease-causing variants, but also that it starts in the index, and then you proceed with the family members. And you do that on every age. That is the last recommendation. So all these recommendations in this last consensus document is about how to test, who to test, and when to test. So the conclusion of both cases here, I believe, should be that the phenotype should be leading when you deal with genetic testing. And my personal belief, I think many agree, is that you only perform genetic testing in strong cases. Random screening is discouraged. That was actually what happened in the second case. That should be discouraged. And I also would like to stress again the importance of multidisciplinary teams. And with that, I end this presentation. Okay, thank you all for attending. Please let us know whether we can do this better or whether you agree with this setup. Thank you all and have a nice day.